Yeah, I'll try to do justification to how to read an X-ray and an MRI in 10 to 15 minutes. As people have said that you have to remember that case history, physical examination are important. And if we go in the
अभिषेक आवाज
sequence,
क्लियर नहीं है. अभिषेक योर वॉइस इज नॉट वेरी क्लियर. थोड़ा
it
इंक्रीज कर दो और रिवर्बरेट बहुत कर रही है. इट्स नॉट वेरी क्लियर.
is clear now?
नहीं वो
Yeah, better. Better.
Better now?
yeah, it's better now.
So we have to go in an algorithm fashion, as Sir Dr. Sudhir has mentioned. Case history is important. Physical examination is important. If we do not follow this and we directly jump to imaging, leaving X-rays or MRI, and the candidate goes and answers an MRI, so you might have lead to a non-rational pathway, and which would lead to more mistakes for a postgraduate. For a standard question which is asked for a postgraduate, he should always know a standard AP and lateral view should always be ordered for any examination. It is faster. It gives you a basic outlook of vertebral shape, the disc shape. It might give you less information about the spine pathology in the early stages. I'll come to the specific X-rays. For the cervical spine, a standard AP and lateral X-ray is done, and which includes from C2 to almost to C6, C7. Sometimes we need an open mouth view, and sometimes we need a similar view for a lower cervical or a cervical dorsal spine. The candidate should understand that we start any examination in the cervical spine from outside to inside. So he needs to remember the retropharyngeal space. In the upper cervical spine, it is around 4 mm. In the lower cervical spine, it is around 8 mm. So easier method is to remember is that you take the vertebral width, and more than half that vertebral width is significant at that space, would be a significant retropharyngeal space increase. The few lines which postgraduate needs to remember are almost these, but for us, if he remembers Chamberlain and McGregor line, which are almost the same of each other, he can make a diagnosis of basilar invagination. He should know what is an Atlanto dense interval. It is around, in an X-ray, around 4 mm is usually standard. In children, it is around 5 mm in the X-ray. In CT, it is around 2 mm. This is sometimes you need to address to instability, so you need to get a flexion extension view. In a flexion view, in a normal view, it looks like that there is nothing abnormal. But once you do an extension view, you find that there is an instability at C1, C2, which is probably due to an os odontotome. Further, sometimes if you X-rays of the C1, C2 are kept, one is a Jefferson fracture, the fracture of the first vertebral arch. If you see the open mouth view, you'll find that there is increased distance between the odontoid and the lateral mass of the C1. So you know that there is a fracture and the widening of the arch has occurred, and probably a diagnosis cannot be reached on an X-ray, and you need to have a CT scan. This is X-ray showing a spondyloptosis of the C2 vertebra, which is also known as the hangman vertebra. I'm not going to go into the classification beyond. This is a fracture of the odontoid fracture because there is a flexion at the C2 vertebra, and plus you see there is an increase of the space, and there's a fracture. This is patient's same X-ray which shows a type 2 odontoid fracture. The D'Alonso classification, everyone should know about it. Coming to cervical facet dislocation, as we told you that you need to have the anterior line, the posterior line, this line along the posterior spinous process, and the spinous line. So any break in this line would lead to show that there is a subluxation. If the subluxation is around 25%, it's a unifacetal dislocation. If more than 25%, it's a bifacetal dislocation. Diagnosis is usually established by getting a CT scan. This clearly shows a locked facet at C6, C7. We can also see in the axial cut, this is also known as the reverse hamburger bun sign, where you find that the bun of the burger is there and the top is missing. So it's also known as a naked facet sign. The postgraduate should be able to differentiate between what is a flexion type and an extension type teardrop. A flexion type is more severe kind. It is associated with a severe kyphosis. It is usually found in the lower cervical spine and it is usually associated with disruption of the PLC. The extension type are usually seen in older patients. They are usually avulsion injuries. They usually happen in the upper cervical spine and they are less severe. One of the most other important fracture, which is the clay-Shoulders fracture, it is an incidental fracture which might be seen in a cervical spine, which is imaged for other reasons. It occurs because the stickiness of the clay and it's an avulsion fracture of the C2 fracture, which leads and a sudden flexion force, which leads to a fracture of the C2.
Dr. Abhishek, please increase your voice. Speak slightly loudly.
Okay.
You can come forward, yeah.
Sometimes we need to have oblique views. These oblique views are usually ordered when we have to see the neuroforamen. This is a patient of cervical radiculopathy, which shows that there is an obstruction of the neuroforamen and there is a posterior osteophyte which is causing that cervical radiculopathy. Am I audible now?
Yeah, it's
Yes.
okay.
You are audible
It's
now.
okay.
Yes, yes.
Better.
Coming to the lumbar spine, a standard APN lateral view is usually ordered. It basically should be from T2 to the sacrum. It should show both the sacroiliac joints and the hip joints. So this basically, you again start from outside to inside. You can give, you can see the paravertebral shadows because of the psoas. You need to see the alignment of the spinous process. Do not comment upon the disc base on the AP view. You can have a look on the facets. You should have a look on the pedicles, the transverse process, and the interlaminar window, which might be decreased in the case of a spinal stenosis. Then you can have a look on the sacroiliac joints and both the hip joints. Similarly, for a lateral view, it basically gives you the vertebral height, the disc height, the neuroforamen, information about the neuroforamen, again the pars, and the spinous process. We need to order sometimes the oblique views. They are basically for spondylolisthesis or a pars interarticularis fracture. You basically have to see the Scottish terrier. A Scottish terrier is a normal sign, which is basically compromised of the nose, which is formed by the transverse process, the eye by the pedicle, the ear by the superior articular process, the neck by the pars, and the front leg by the inferior articular process. So once you have a beheaded Scottish terrier sign, which is a pathognomic of a pars interarticularis fracture or a spondylolisthesis. The other important sign which may be asked is an inverted Napoleon hat sign. This is the Napoleon hat sign. So if you have an inverted Napoleon hat sign, basically you are seeing the L5 vertebra end on, which usually signifies that you might be seeing a high-grade listhesis. We need to order sometimes flexion extension views. They basically give us information about the instability. So you get a flexion extension view. You have a vacuum disc, which again signifies there is some potential instability at that level. Standing X-rays, I will not go into the detail, but they give us basically the balance. They start from the C2 to both hips. They are the loading X-rays. They give us information about the lumbar balance, the SVA, PI, LL, the lumbar lordosis, and the pelvic tilt. I will not go into the details. They will be dealt in the scoliosis. The other thing, a candidate may be asked how to draw a Cobb's angle. It is basically drawn along the end vertebra. So you draw a line along the upper end plate of the upper vertebra, a lower on the lower end plate, the lower end plate of the lower vertebra. So basically you have, and which vertebra you need to see are the vertebra which have the least, which will have not the disc space parallel. A CT scan sometimes is asked when you would order a CT scan. So a CT scan is basically a multiple X-rays, and you basically see different shades of gray, the 0 being the normal and air being the most dark. So, and the bone being the most white. So it is the different shades of gray which you need to see. A 1 mm standard CT scan is usually done. The images can be re-engineered to give us a 2D image then a 3D image, and then further it can be used for 3D printing. A contrast CT scan does not have so much limited, has no very limited role in spinal pathologies. A myelo CT may be ordered when there is MR incompatibility because of any prosthesis or because of any heart work, the pacemakers. It's an excellent choice for upper cervical injuries, and in emergency situation we will need to have a faster access. So because a CT can be done from top to bottom in a very fast situation, and it also gives us information about misplaced hardwares. Coming to the MRI, MRI basically is that the magnet leads to stimulation of the water molecule, and then it relaxes, and this relaxation is basically captured again by the camera, and this then is reformatted to give us the images. So it gives a good contrast between different tissues of the body. It gives very poor detail of the bone. The candidate should know which image he's dealing with, and the key is the CSF. And the mnemonic is water, World War II. So you remember water is white on T2 weighted images. So we come to specific images. This is a T1 weighted images because the CSF is black. The normal would be is hyper intense on a T1 weighted image, and the mnemonic is my best friend is pretty cool. So these are the things which you can lead to. You should be worried about whenever you see a hypo intense shadow in a T1 weighted image. In a T1 weighted image, if you have a hypo intense shadow, which is basically a black shadow, this basically signifies that the bone marrow has lost and there is increased water content. So there is some process which is going wrong. So there might be an abnormal low signal on a T1 weighted image, which might give you some information that you might be dealing with a trauma, infection, or a cancer. Now, this is the same image of a same patient. Now a T2 weighted image because the CSF is now white. So this is a T2 weighted image. And these are the things which are usually seen black on a T2 weighted image: calcification, hemoglobin, fibrous, and tumors. And anything which is white on a T2 weighted image is basically considered that there is increased water content, and it should be considered as pathological. And this might give you an indication that you might be dealing with trauma, infection, or cancer. So this is the same patient, and you have a complete high signal intensity, which is signifying that you are dealing with a multiple myeloma. There are certain special sequences sometimes which might be there available. The one which is most commonly is the stir images, which are usually available now with the MRI. They basically show the high water sensitivity, and water is basically bright. So it basically will give you information, and you see and compare the images to a T1 weighted image, and you compare it to the T1 weighted image, and you will find that water is white. So this is again a significant that there is increased inflammation, and there is a MRI of a spondylodiscitis. Few other images which are now commonly available are the diffusion weighted images. These images are basically dependent on the water mobility. The faster the water molecule basically diffuses, the weaker is the signal which is recorded. So a dark signal would signify blood and edema. This is basically used when we are having some confusion about benign osteoporotic fracture and a malignant osteoporotic fracture. A benign osteoporotic fracture would usually appear similarly as a dark appearance. Whereas if it is hyper intense, you basically consider that you might be dealing with a malignant osteoporotic fracture. Few cases why would you need a contrast enhanced MRI? Basically, it is done when you need to do evaluate a previous surgery, and you might be used when you want to show enhancement around inflammation neuroplasms. So this is an example. First is the spondylo case of a tubercular spine. You find that there is increased phlegm, so there is increased inflammation, and there is peripheral enhancement. Now you have a patient, I'm showing you the image where you can compare a recurrent disc to a scar tissue. In a recurrent disc, basically the disc material does not have any vascularity, has no vascularity. So there will be no contrast uptake when you have a recurrent disc. Now, if you have a scar tissue has some vascularity. So there will be peripheral enhancement of the scar tissue. So this is a case where you have might need a contrast enhanced MRI. Few examples I would like to give where a postgraduate is asked what are the differential diagnoses of vertebral plantar? So the mnemonic is I built, and it is basically infection, metastasis, eosinophilic granuloma, the most common, the lymphomas, and T for trauma or tuberculosis. The tuberculosis can be an atypical tuberculosis. How do you differentiate between a tubercular and a pyogenic spondylodiscitis? The postgraduate should remember that a post-contrast image will show an ill-defined whenever you're dealing with a pyogenic, because the pathology is more aggressive as compared to a tubercular spondylitis. Therefore, the post-contrast images will be having a well-defined lesion. Plus, you will find ring abscesses, which are more commonly seen in a tubercular. These are the ring peripheral enhancement and the ring abscesses, which are more commonly seen in the tubercular spondylodiscitis. The other thing which is seen is the disc destruction. Since spondylodiscitis, pyogenic usually starts on the disc, as compared to the vertebra, which the tubercular, which starts from the end plates. So the disc is usually preserved in the tubercular spondylitis as compared to a pyogenic spondylitis. The bony destructions is very common in pyogenic spondylitis as compared to tubercular spondylitis. The other important thing which a candidate is asked is how to differentiate between a benign osteoporotic fracture and a malignant osteoporotic fracture. You should remember that even in an MRI, that if you have normal posterior elements, that you might be dealing with a benign vertebral fracture as compared to a malignant vertebral fracture, where you might be dealing with an enhancement or a dark shadow in the posterior elements. The MR signal basically shows an irregular margin. These are smooth margins in a benign VCF. In a malignant, there is no smooth margin. In the diffusion weighted images, as I've clearly shown, there is no restriction of diffusion, so they will appear as bright. There is increased diffusion. So in the benign, there is no restricted diffusion, so they appear basically as dark. Whereas in malignant VCF, there is increased diffusion. So there is basically, they will appear hyper intense. Sometimes you might be asked, how will they appear in the PET? So you need to remember that the SUV is basically standard below the liver level. So you will be dealing with a low grade lesion as compared to a high grade lesion. In summary, I'm giving this chart. Every postgraduate should have this chart available. So you can, for a spinal TB is basically seen in more commonly in the thoracolumbar region. A pyogenic is more commonly seen in lumbar. So this chart is easily available. So every postgraduate can have a look at this chart and go about it. Thank you.